Good morning, everybody. As introduced, I'm Dr. Ugochi. I'm a senior registrar in nephrology at the University of Nigeria Teaching Hospital, Enugu State. And please permit me to rest on already established protocol and present diagnosis of HIVAN. Are there predictors to distinguish HIVAN from non-HIVAN chronic kidney disease? Okay, so I'll be using this outline. We know that infection with human immunodeficiency virus has protein manifestations, and the kidney happens to be a very important and common target in this scenario. And kidney disease has been documented to be the fourth most common cause of death amongst patients who are infected with HIV, and HIV-associated nephropathy, that is HIVAN, has been noted to be the single most common cause of chronic kidney disease amongst HIV-infected patients, and it's the third leading cause of end-stage renal disease amongst African Americans aged 20 to 64 living in the United States. There has been documentation of a decline in HIVAN prevalence, and this is more commonly seen amongst HIV-infected populations who have access to care, especially the highly active antiretroviral therapy, HART. And there has been this controversy whether HIVAN is an early or a late manifestation of HIV infection, as HIVAN has been documented in settings of acute seroconversion and also been seen in advanced HIV infections. However, literature suggests that there's no definitive way other than kidney biopsy to be able to differentiate a patient who has HIVAN from someone who has non-HIVAN lesions, because 30 to 55% of patients who we are clinically assumed to have HIVAN at the time of biopsy end up having lesions other than HIVAN. Unfortunately, in developing world, especially in Africa, renal biopsy is not easily accessible. So the clinician wonders, if I cannot biopsy my patient, is there an easier way to predict what the patient likely has? So traditionally, when someone has HIV infection and comes down with chronic kidney disease and presents with little or no edema, normal blood pressure, normal size or enlarged echogenic kidneys, azotemia with rapid progression to end-stage renal disease, and bland urinary sediment and low CD4 count, some people will think that this patient most likely have HIVAN. But is that actually the case? Okay, so this study was aimed at to identify a more accessible ways to predict HIVAN in HIV-infected patients who has chronic kidney disease. So between April 2016 and August 2018, we biopsied a total of 66 adult HIV-infected patients who had at least stage 3 chronic kidney disease. We, however, excluded patients who had hypertension for more than 2 years. We also excluded patients who had diabetes mellitus, other viral infections, including hepatitis B and hepatitis C infection, obstructive uropathies, malignancies, systemic diseases with renal affectation, and indeed, we excluded any patient who had any contraindication for renal biopsy. Then we obtained ethical clearance from our hospital ethical committee, and patients who participated in this study gave informed written consent. Data was analyzed using SPSS version 22, and we represented our data in forms of frequencies, percentages, means and standard deviation, and we used the appropriate tests, and a p-value of less than 0.05 was considered to be statistically significant. So out of the 66 patients we biopsied, 58 of them were found to have renal tissue specimens that were considered to be adequate to make histological diagnosis using light microscopy and immunohistology, and the patients were aged 18 to 64 years. We had 25 males and 33 females. In all, we had 13 of the patients had renal histology that was compatible with diagnosis of HIVAN. They had the collapsing variant of focal segmental glomerulosclerosis. And the remaining number of patients, that is 77.6% of them, had lesions that were not HIVAN. So this slide tries to show us the histological spectrum of diseases that we found on our patients. And you see there significantly that HIVAN remained the single most common diagnosis that was made, but the prevalence is obviously less than what has been documented in most African populations. So we had a prevalence of HIVAN of 22.4%. Then we also noted that this is closely followed by focal segmental glomerulosclerosis, which is not otherwise specified, which occurred in 12 people, accounting for 20.7% of our biopsy population. Then we also noted that despite the fact that all our patients had chronic kidney disease, at least stage 3, 8 of them, constituting 13.8%, had normal histological findings. But remember, this was light microscopy and immunohistology. So like we said before, traditionally, when someone has HIV infection, has chronic kidney disease, and has very low CD4 count, most people will assume that this patient is most likely going to have HIVAN. But this table tries to look at the World Health Organization classification of immunological classification of HIV infection using the CD4 count. So this slide shows that whether the patient had a CD4 count of less than 200 or a CD4 count of greater than 500, there was still this probability of having both HIVAN and non-HIVAN lesions. So there is no sex difference in the distribution of patients who had HIVAN and non-HIVAN. But we know that, like in the traditional description of a patient who has HIVAN, you don't actually expect so much edema. But we noted that we had equal number of patients in the two groups that had edema. But if you look at the proportion in the HIVAN group and the non-HIVAN group actually had a higher proportion of patients who had edema. Then we also noted that it's expected that patients who have HIVAN will have normal sized or enlarged echogenic kidneys. But we found out that one of the patients that actually had HIVAN had a normal size and not an echogenic kidneys. And then when we look at significant proteinuria in this study, actually we used distinct proteinuria. We found that all the patients who had HIVAN had significant proteinuria, but only 27 out of the 45 patients who had non-HIVAN lesions actually had significant proteinuria. And this was found to be statistically significant. Then when we looked at World Health clinical staging of established HIV infection, we first of all categorized the patients into asymptomatic and symptomatic group, and we find that the difference is actually statistically significant. The patients who had HIVAN were more likely to be symptomatic, and this is in keeping with what has been previously documented, that oftentimes HIVAN is documented in the setting of advanced HIV infection. Patients who had HIVAN were also noted to be younger, and this was also statistically significant. But if you look at this table, we found that though that patients who had HIVAN had a lower mean systolic and diastolic blood pressure, it wasn't actually statistically significant. So using blood pressure just as a measure to predict HIVAN wasn't going to be helpful. Then we also see that despite the fact that the patients who had HIVAN had a higher mean serum creatinine and CD4 counts, it was also not statistically significant. And of course, the findings on ultrasound was actually not significant. So, contrary to the documentation that HIVAN is essentially a late and not an early manifestation of HIV infection, we found HIVAN occurring across all the World Health Organization immunological and clinical stages of established HIV infection. Then we noted that there's a predominance of non-HIVAN lesions in this study, and this tends to agree with the changing epidemiology of chronic kidney disease in the HAT era. Okay. So in conclusion, we say that although HIVAN diagnosis was significantly associated with being younger, having symptomatic World Health Organization classification for clinically established HIV infection, and a higher degree of proteinuria, most of the traditional clinical and laboratory characteristics, which we have ab initio believed to predict a histological diagnosis of HIVAN, including normal blood pressure, bland urinary sediment, normal size or enlarged echogenic kidneys, and low CD4 counts, we are not found to be significantly associated with a histological diagnosis of HIVAN. So we say that that kidney biopsy, even though it's not readily available in resource-poor setting, still remains the gold standard for adequate diagnosis of the histological issues that the patient might have, and thus kidney biopsy should always be done where feasible. However, we do recommend that larger studies involving larger number of patients are required to be able to confirm if indeed the degree of proteinuria, being younger, and advanced, WHO advanced clinical staging of HIV will actually predict diagnosis of HIVAN. And these larger studies can also help to find other predictors of HIVAN. Thank you so much for listening.